In the decades following the Second World War, clinical depression was largely treated as a taboo. In working-class neighborhoods, deep psychological distress was routinely hushed up, surrounded by silence, and treated as a source of deep personal shame. When the medical establishment did discuss mental illness, the conversation was split into two distinct camps. On one side was Freudian psychoanalysis. This model framed severe distress as an individual failure, tracing the pathology back to unresolved internal conflicts or early childhood trauma. On the other side was the emerging field of biomedical psychiatry. This faction categorized severe cases as endogenous depression, a spontaneous internal misfire of the brain's chemistry that occurred completely independent of external events. Despite their fierce disagreements, both models shared the same critical blind spot. They operated entirely inside the patient. They excluded the material realities of housing, income, and physical community from the diagnostic equation. This binary approach left the actual lived experiences of working-class patients scientifically invisible. The medical establishment offered no framework to explain why these specific populations were suffering. George Brown and Tirril Harris approached this problem from outside the psychiatric establishment. Trained as anthropologists, they were accustomed to observing how social structures and cultural systems dictate human behavior. They identified a glaring contradiction in the established medical consensus. If clinical depression is strictly an internal biological defect or a private psychological failure, working-class communities should not experience it at drastically higher rates than the middle class. This is the abstract from their 1975 publication detailing the Camberwell study. To investigate this class disparity, Brown and Harris bypassed the clinic. They went directly into the homes of a random sample of women living in South London, conducting exhaustive interviews with both clinically depressed subjects and a non-depressed control group. Instead of simply cataloging symptoms, the researchers built a forensic timeline. They mapped out the precise occurrence of severe life events over the 12 months leading up to the onset of the subject's depression. They were testing a specific hypothesis, that abstract structural forces, such as economic insecurity and social isolation, physically manifest inside the body as clinical mental illness. The data revealed that clinical depression rarely acts like a random lightning strike. It almost always possesses a specific, identifiable point of genesis within the patient's immediate environment. Brown and Harris classified these catalysts as provoking agents. These took the form of acute, severe life events, like a sudden job loss or an eviction, or major chronic structural difficulties, such as long-term housing insecurity. When the researchers compared the timelines of the two cohorts, a massive statistical divide emerged. This chart shows the distribution of severe events between the two groups. In the non-depressed control group, 20% faced a significant negative event in the preceding year. Among the depressed cohort, 68% experienced a severe event prior to the onset of their illness. A 48-point gap cannot be explained by biological randomness. It demonstrated that severe environmental stress acts as the primary catalyst for clinical depression. Yet the presence of a provoking agent alone was incomplete. Many women in the control group experienced severe trauma, but did not develop clinical pathology. The environment provided the match, but the researchers still need to know why certain individuals caught fire, while others were able to process the grief and recover. To understand why some subjects broke down while others exhibited psychological resilience, Brown and Harris analyzed the background conditions of their subjects' lives. They discovered vulnerability factors, social deficits destroying underlying resilience. These include lacking a confiding relationship, having 3 or more young children, lacking employment, and the early loss of a mother. When these latent vulnerabilities intersect with a provoking agent, the risk of pathology explodes. The math was devastating. If a severe negative event struck a woman who lacked a supportive partner and had no close friends, her probability of developing clinical depression was 75%. Psychological resilience is not an inherent biological trait. It is a socio-environmental resource, and one's material circumstances can systematically strip it away. Applying this vulnerability stress model resolved the initial epidemiological mystery regarding social class. Working-class demographics operate on a steep social gradient. They are statistically exposed to a much higher frequency of severe triggering events, like sudden unemployment or financial crisis. Simultaneously, those identical neighborhoods suffer deeper, concentrated structural vulnerabilities. The exact populations facing the most frequent crises also possess the fewest resources to absorb them. By contrast, middle-class wealth and status function as a social buffer. Financial security and broader social networks provide stabilizers that actively protect individuals from succumbing to identical triggering events. This established a complete biopsychosocial synthesis. External structural inequality, poverty, housing instability, and labor conditions literally gets under the skin to dictate internal clinical pathology. The Camberwell study proved that working-class depression is not a failure of mental toughness, nor is it a matter of bad genetics. It is a highly predictable epidemiological outcome of social architecture. The 1978 publication of these findings represented the first major scientific inquiry into the social origins of mental distress. The response from the medical and academic establishment was immediate, fierce, and highly coordinated. They aggressively sought to invalidate the study's methodology. In 1979, psychologist M.B. Shapiro published a scathing critique. He dismissed the entire concept of the interview-based model, labeling the study's procedures as subjectivist, unvalidated, and rooted in medical folklore. This friction was ideological. Late 1970s psychiatry was fighting for legitimacy as a hard medical science. To secure that status, the field demanded rigid, symptom-based biomedical checklists. Factoring in nuanced social meaning was viewed as a step backward. This shift occurred alongside the rise of the pharmaceutical industry. Designing and marketing psychiatric drugs required localized internal biological targets. They needed the problem to be contained entirely within the brain. If clinical depression stems from eviction notices, wage stagnation, and a lack of childcare, the required intervention is political reform. It is a problem that cannot be solved with a prescription pad. The establishment attacked the Camberwell model because its conclusions directly threatened their absolute professional authority over mental illness. The biomedical orthodoxy secured its victory in 1980 with the publication of the third edition of the Diagnostic and Statistical Manual of Mental Disorders. The DSM-3 codified depression strictly as a decontextualized checklist of symptoms. The patient's structural reality and material conditions were entirely erased from the diagnostic criteria. By framing severe emotional distress solely as an individual's brain disease, society is absolved of the daunting, expensive task of addressing poverty, isolation, and structural reform. The empirical data generated by Brown and Harris proves that attempting to diagnose mental illness by stripping away its social context produces an inherently incomplete science. True clinical understanding requires looking past the individual skull and rigorously analyzing the societal structures that distribute suffering and protection.